Hello everyone and welcome back to the channel. If you've been diagnosed with rheumatoid arthritis, one of the biggest questions you may have is, can rheumatoid arthritis actually go into remission? Can the inflammation disappear? Can your joints feel completely normal again? And perhaps the biggest question of all, if you reach remission, does that mean you can eventually stop your medication? The encouraging answer is that yes, rheumatoid arthritis can go into remission, and with modern treatment, remission is a realistic goal for many patients. But remission doesn't necessarily mean that rheumatoid arthritis has been permanently cured, and understanding that distinction is extremely important. I'm Dr. Naveen Bhadauria, consultant rheumatologist at Pure Rheumatology London, and in today's video, I'm going to explain what remission in rheumatoid arthritis actually means, how we achieve it, why early treatment matters so much, whether joint damage can still occur, and what happens to your medication if you remain well for a long period of time. Let's start with the most important question. What exactly do we mean by remission? Rheumatoid arthritis is an autoimmune inflammatory disease. The immune system becomes misdirected and causes inflammation within the lining of the joints. This produces the symptoms many patients recognize: pain, swelling, warmth, and particularly prolonged morning stiffness. If that inflammation continues uncontrolled, it can eventually damage cartilage and bone within the joints. Historically, our expectations for rheumatoid arthritis treatment were actually quite modest. The aim was often simply to improve symptoms and slow down joint damage. Modern rheumatology is completely different. Today, our goal is ideally to get somebody into remission, or at the very least, into very low disease activity. Remission essentially means that the rheumatoid arthritis has become very quiet, with little or no evidence of active inflammation. That usually means very few or no swollen joints, minimal symptoms from active inflammatory disease, low inflammatory markers, where these are informative, and an overall assessment suggesting that the disease is well controlled. We use formal measures such as DAS28 and other remission criteria to help assess this objectively, rather than simply asking, how do you feel? And that's important because feeling better and actually being in remission aren't always exactly the same thing. Someone may feel dramatically better but still have several swollen joints. Conversely, somebody may have no active inflammatory arthritis but still experience pain from osteoarthritis, previous joint damage, or another musculoskeletal problem. So remission isn't simply about having no pain. It's about controlling the inflammatory disease itself. Now, can everybody with rheumatoid arthritis achieve remission? Unfortunately, not everybody will. Rheumatoid arthritis behaves differently from one person to another. Some people respond beautifully to their first disease-modifying medication. Others need several different treatments before we find the right one. But our ability to achieve remission has improved enormously because we now have far more treatment options. We have conventional DMARDs such as Methotrexate, hydroxychloroquine, and sulfasalazine. We have multiple biologic treatments targeting different parts of the immune system, and we now have targeted synthetic treatments such as JAK inhibitors. So if one approach doesn't work, that certainly doesn't mean we've reached the end of the road. And there's one factor that can make an enormous difference: how early we treat the disease. There's a concept in rheumatology sometimes described as the window of opportunity. The idea is that there may be a period relatively early in rheumatoid arthritis when controlling inflammation aggressively gives us the best opportunity to alter the course of the disease. This is why I repeatedly emphasize the importance of recognizing rheumatoid arthritis early. Persistent swelling of the small joints of the hands or feet, prolonged morning stiffness, difficulty making a fist in the morning, and symmetrical inflammatory joint symptoms shouldn't simply be ignored for months. The earlier we diagnose rheumatoid arthritis and start appropriate disease-modifying treatment, the better our chance of controlling inflammation before irreversible joint damage occurs. And this leads to another important concept called treat to target. Treat to target means that we don't simply start methotrexate and then leave somebody on the same treatment indefinitely regardless of what happens. We define a target, ideally remission or low disease activity, and assess whether we're actually reaching it. If inflammation remains active, we may optimize the methotrexate dose, change treatment, combine medications, or move towards biologic or targeted therapy when appropriate. Think of it almost like treating high blood pressure. You wouldn't prescribe a blood pressure tablet and then never check the blood pressure again. You measure the response and adjust treatment until you reach the target. Rheumatoid arthritis should be approached in a similarly structured way. Patients sometimes ask me whether having a positive anti-CCP antibody or rheumatoid factor means they'll never achieve remission. The answer is no. Anti-CCP positivity can be associated with a greater likelihood of persistent or erosive disease, but it certainly doesn't mean remission is impossible. I've looked after many patients with strongly positive anti-CCP antibodies who have achieved excellent disease control. Blood tests help us to understand the disease and its prognosis, but we treat the patient, not simply the antibody result. Now let's address something that causes a lot of confusion. If you reach remission, are you cured? Usually, we shouldn't think of it that way. Rheumatoid arthritis is generally considered a chronic condition. Remission means that the disease activity has been suppressed to a very low level or is clinically absent. It doesn't necessarily mean the underlying tendency towards rheumatoid arthritis has permanently disappeared. A useful analogy is a fire. Treatment may put the fire out completely, and there may be no visible flames at all, but under the right circumstances, it can potentially reignite. That's why we continue monitoring patients even when they're doing extremely well. And that brings us to probably the question I hear most often. If I'm in remission, can I stop my medication? Sometimes medication can be reduced, but this needs to be done carefully. If somebody has achieved sustained remission for a meaningful period, particularly if they're doing exceptionally well, we may sometimes consider gradually reducing treatment. But stopping everything suddenly simply because you feel better is usually not a good idea. One of the common reasons people feel well is precisely because the medication is working. I sometimes explain it like this. If you take medication for high blood pressure and your blood pressure becomes normal, that doesn't necessarily mean you never had hypertension. It may mean the treatment is controlling it. The same principle can apply to rheumatoid arthritis. If treatment is reduced too quickly, the disease can flare, and repeated flares aren't simply inconvenient. They may expose the joints to further inflammation and potentially damage. So medication reduction should be a shared decision between you and your rheumatology team, taking into account how long you've been in remission, how severe your original disease was, previous flares, your antibody status, imaging, and other individual factors. Another interesting question is whether somebody can be in remission but still experience pain. Absolutely. This is really important. If you've had rheumatoid arthritis for many years, you may have some structural joint damage. You can also develop osteoarthritis, tendon problems, or other musculoskeletal conditions completely independently of rheumatoid arthritis. So if somebody in remission develops knee pain after walking, for example, that doesn't automatically mean their rheumatoid arthritis has returned. We need to distinguish pain from active inflammation. This is where clinical examination and sometimes ultrasound or other imaging can be extremely helpful. What about lifestyle? Can diet, exercise, or supplements put rheumatoid arthritis into remission? Healthy lifestyle measures are extremely valuable. Regular exercise helps maintain muscle strength, cardiovascular health, and function. Maintaining a healthy weight can reduce mechanical stress on joints and may improve overall inflammatory health. Not smoking is particularly important because smoking is associated with rheumatoid arthritis and poorer outcomes. A Mediterranean-style diet is a sensible approach for general health, and omega-3 intake may have modest benefits for inflammatory symptoms in some patients. But lifestyle should complement effective rheumatoid arthritis treatment rather than replace it. If somebody has multiple swollen joints and active inflammation, I wouldn't recommend trying to achieve remission using supplements or dietary restriction instead of disease-modifying treatment. The aim is to control the inflammation before permanent damage occurs. So what are the most important things you can do to maximize your chances of remission? Firstly, get rheumatoid arthritis diagnosed and treated as early as possible. Secondly, take disease-modifying medication consistently and discuss side effects rather than simply stopping treatment yourself. Thirdly, attend your monitoring appointments so that your rheumatology team can determine whether you've genuinely reached the treatment target. Fourthly, look after the things you can influence. Don't smoke. Remain physically active, maintain a healthy weight, and look after your cardiovascular and bone health. And finally, remember that if your first treatment doesn't work, that isn't treatment failure overall. We have many different treatment options. One of the biggest changes I've seen in rheumatology is that our expectations have become much higher. We don't simply want patients to tolerate rheumatoid arthritis. We want them to live well despite it. For many patients, that means going to work, exercising, traveling, looking after their families, and sometimes going days or weeks without really thinking about their arthritis at all. That is what successful modern rheumatoid arthritis treatment can look like. So can rheumatoid arthritis go into remission? Yes. For many patients, remission is absolutely achievable, particularly with early diagnosis, appropriate treatment, and careful monitoring. But remission isn't necessarily the same as cure. The disease can return, which is why monitoring remains important and why medication should never simply be stopped without discussing it with your rheumatology team. And if you've recently been diagnosed with rheumatoid arthritis, I want you to take something positive from this video. The outlook for rheumatoid arthritis today is completely different from what it was several decades ago. We have effective conventional treatments, biologics, targeted therapies, and increasingly sophisticated ways of monitoring disease. Our goal isn't simply to slow rheumatoid arthritis down. Our goal is to get you as close to completely free from active inflammatory disease as we possibly can. If you found this video useful, please give it a like and subscribe to the channel for more evidence-based videos about rheumatoid arthritis, autoimmune disease, and modern rheumatology treatments. And let me know in the comments if you'd like me to make a follow-up video specifically answering the question, I'm in rheumatoid arthritis remission, can I stop my medication? I think that's a topic that deserves a video of its own. Thank you very much for watching, take care, and I'll see you in the next video.